Okay, it's 2:31 and I will start the lecture. And this is the Essentials of Interventional Radiology. I am one of the main interventional radiologists at the Southern California Permanente Medical Group in Riverside campus. And you are in the second lecture series. So what I want to do before I start is just give credit where it's due. I did not make all of these slides. I did borrow some from my partners at Kaiser Private Practice as well as Baylor and from the British Society of Interventional Radiology with these physicians. And so some of these slides are from them. So before I go into the nitty-gritties, the specifics of interventional radiology, I want to give you an overview of what I want to do. I want to talk about IR as a subspecialty because what I noticed in clinical practice over the last 18 years is a lot of interns and residents and even attending physicians, they really don't know the scope of what interventional radiologists can offer their patients in terms of minimally invasive procedures. And the trend now is minimally invasive, minimally invasive, minimally invasive in everything. And we really try to avoid surgery if we can. So I want to talk about the role of interventional in your interventional radiology in your particular specialty. And I can't think of any one field that will not be affected by interventional radiology except maybe psychiatry. Is anyone going into psychiatry here? There's about 6, 7 of you here. Hopefully more will join. No psychiatrists. Okay. Whatever you decide to do, I'm almost sure that interventional radiology the physicians in this field will help you in the future. And I want to talk about the common diseases referred to interventional radiology. Okay, it says here soon the demo will be. Okay, good. Great. Psychiatry is a great field. In psychiatry, I don't think you'll probably deal with interventional radiologists, but what I want to do is talk about the common diseases of, there's tons and tons of diseases out there, but I want to talk about the common ones, the more clinically relevant diseases that we see often in the hospital setting. Talking about the anatomy, the pathophysiology, and then targeted interventional radiology treatments that will help all of you, especially when you start your internship and residencies next year. So I know that Dr. Darius Liu will be talking about interventional, and I will be talking about, there are going to be some common topics, but the majority of the lecture will probably be different. We'll be covering different disease entities and targeted treatments. So the common thing that we're going to talk about is, what is IR? What is interventional radiology? And it's not a very old field. It's not like surgery or internal medicine where it's been around for many, many, many years. It's probably in the last 50 years, I would say, interventional radiology has been really growing exponentially. Some people like to refer, this is a quote, interventional radiology is a pinhole surgery performed with the aid of all these imaging modalities by specially trained doctors called IR physicians, or some people say interventional radiologists are subspecialists who not only diagnose disease by imaging, but they treat patients. And that's a good summary of what interventional radiology physicians do to lay folks' understanding. But for you guys, it's going to be a little bit more focused. Interventional radiology is a accredited subspecialty in radiology since 1970. And the IR physicians or interventional radiologists perform these minimally really cool procedures that not only expedite patient hospitalization and discharge, but it really is safe for these patients. It is better for many patients. And interventional radiologists will be involved with all these, not limited to this list, but they will be involved in gastroenterology, hepatology, to gynecology, to ENT, to ortho, intervention cardiology, oncology, and it's just a huge field that we are challenged to help in terms of many, many different fields. The rapid growth of the number of IR procedures, it's definitely increasing in complexities, and we IR physicians, like other physicians in specialized fields, need continual education. So most of the procedures will be procedures that require less than 5 millimeter incisions, very, very, very minimally invasive. Rarely we would do incisions greater than that for portacatheter placements, things like that, but the majority of the procedures will be done with very small incisions. A lot of procedures, in fact, all arterial vascular procedures are performed initially by access, and there's arterial access and then there's venous access. But for the arterial, this is pretty much the cellular technique that we follow. This is a very basic technique, but it is how we access the arteries. We use now, they used to use bigger needles, 18 gauge needles that go through and through, but now I think majority of interventional radiologists don't do this. This is an older slide, I apologize, but we would start here with a smaller micropuncture needle, like a 21 gauge or so, and hit the artery anteriorly, just one wall. You get flashback of blood. We place a wire and we upsize this hole to accommodate a small sheath. And that way we place catheters in and out through the sheath without trauma to this artery. So we place a sheath and now we have access. This is just a very basic, safe technique to access the arterial tree. And now you have access to any blood vessel, any arterial vessel, pretty much in the entire body. Just out of curiosity, if you guys have any questions, just I have this list in front of me so I can see your questions pretty clearly. So go ahead and ask any questions. I'd like to answer questions as we go along. Everybody still awake? Okay, thank you. Again, please ask any questions. I love questions. I like to discuss questions. This is a very important process of these lectures. And I do not want this to be just a boring lecture where you get nothing out of it. If you can get a couple, maybe 2 or 3 key important points out of this lecture and ask questions, we can discuss it. It would be very, very useful that way. Okay, so this is, again, I'm sorry, this is a little bit of an older slide, but the concept and the procedure itself is pretty much consistent today. This is just a very basic, it's an older aortogram. This is the ascending aorta, descending thoracic aorta, aortic arch of the great vessels. This is a catheter and shoot X-ray dye, and this is huge pseudoaneurysm off of the aorta. This is very, very life-threatening. Traditionally, they would go in there and do cardiothoracic surgery. But in a select group of patients, you would place what they call a stent graft to exclude this aneurysm lumen. And now you have this lumen that is contained and you have excluded the aneurysm, pseudoaneurysm. All right, that was just an image just to keep you awake. All right, so sedation. Almost all procedures will require only local anesthetic, but we do a considerable amount of procedures where moderate or conscious procedural sedation is needed. I would say the majority of the procedures that require conscious sedation or procedural moderate sedation will require what we call the fentanyl. It's a narcotic that's very fast acting with a short half-life. And Versed, and this is a benzodiazepine that also has a very effective but very short half-life. But ketamine, I put this down because we're thinking about using this, but this is considered deep sedation, and interventional radiologists rarely use this without anesthesiologists. But for the purposes of this talk, fentanyl, remember fentanyl, I use up to 200 mics, and Versed are the main conscious sedation medications besides the local anesthesia with lidocaine. Majority of the patients in interventional radiology lab suites, they go home, it's an outpatient procedure. A lot of them are, or if you're covering inpatients, they can go back to their rooms. If it's very invasive procedure, we monitor them in interventional radiology suites longer, or they go back to the ICU units. But a lot of the procedures are outpatients that require no hospitalization. So I know it's lagging on your, I want to give you a bird's eye view of what we do. Internal bleeding, we treat those. We treat targeted cancer treatments. And I'll go in a little bit more detail later on for each. Aortic aneurysms, both thoracic and abdominal aortic aneurysms, and I'm going to hit that a little bit later in more detail. And blocked bile ducts, mainly due to stones or usually cancer, cholangiocarcinoma or pancreatic cancer that causes biliary obstruction. Uterine fibroid embolizations is something that is very, very commonly done now. We get the majority of our referrals are from gynecologists for fibroid disease. I'll talk about that. Blocked kidneys is another term to describe hydronephrosis from stones or kidney cancers. We do tons and tons of hemodialysis interventions, whether it's venous access or AV declotting for the fistulas. We treat varicose veins as outpatients. We treat arteries, bone and spine, and the list goes on, blood clots in all types. And we also treat AVMs with glue. So let's see here. I think there we go. These are just pictorial sort of angiograms that I just talked about. And let me show you exactly. Okay, now don't look at these. And this is not meant to read every one of these procedures, but this is a sort of a bird's eye view of what we do, what I do in interventional radiology here at Kaiser Riverside Medical Center. And this is just to describe hepatobiliary type of procedures, the GI procedures we do. And these are just regular procedures that we do. It's not rare procedures we do, but these are just an example of what we do on a regular basis. OBGYN, fibroembolization, all these procedures, endocrine, vascular, neurology or neurosurgery, we help them out. Nephrology, again, this slide is to demonstrate the scope of different procedures we do. Urology, lots of nephrostomies. Pulmonary, we do a lot of drainages, long-term drainages, angiograms and embolizations for severe hemoptysis. Oncology, there's very, very interesting things going on there. So interventional radiologists, the bleeding is probably a huge component of what we do, but stopping the uncontrolled bleeding, whether it's from trauma, whether it's from childbirth or from cancer. There's just a lot of different reasons of abnormal bleeding that we treat. And we treat blood vessels as small as 2 millimeters, and that's by way of microcatheter usage, that are tiny little catheters that look like little worms that are have luminal diameter or luminal French size of up to 2 to 3 French. Blood vessels can also not only be blocked embolization-wise, but we also coat them with either stenting or revascularization. Here is an example of a patient. This is very typical, common procedure that we do here at Riverside. And this is a patient with severe bleeding into, this is a colon. This is an angiogram. Here's a catheter into one of the vessels in the right lower quadrant, a microcatheter injected, and then these little segmental branches are normal, but you see this blush, this little extravasation of contrast, meaning that it's bleeding, it's extravasating contrast. This is what an active bleed looks like in the bowel. And of course, these patients drop their hemoglobin over hours to days. And we usually get these patients where the endoscopist, GI physicians, can't find it, or they cannot stop it, which is not uncommon. And the next slide shows how we access these smaller vessels, and we place this catheter, and these are what we call coils, microcoils. There's big coils and there's microcoils. These are made of usually platinum, very expensive, but these are very effective. You can see it well, and you can stop the bleeding immediately. And surgery and bowel resection and endoscopy is avoided again. All right, so we're just going sort of in generalities here, but dialysis catheters for hemodialysis, this is probably bread and butter. Tunnel catheters we place into the veins. Again, this is sort of an example of what an obstructed bile duct system looks like. This is the patient's liver, and this is the common bile duct. This is actually the cystic duct and the gallbladder filled with X-ray dye, and there's a blockage here from cancer. So we place stents in through the percutaneous route, and we can talk about that later. Vertebroplasty, this is a lateral view of the spine with compression fractures, and we inject what we call methacrylate, which is medical cement. We inject it and stabilizes the movement within the fractures, and this is mainly for pain control. Very effective. A little bit controversial due to some recent published papers that say that it really isn't effective, but in my practice over almost 20 years, it's very, very effective procedure, vertebroplasty, for pain control from compression fractures. Uterine fibroids, a very common procedure. Again, this is what a fibroid looks like, a lateral view of the female pelvis, big fibroid mass that causes pain and bleeding. And we can go about the kidneys. I think we're going to keep going here. Good question. So Elias asks, is that for acute vertebral body fractures? And that's actually a very good question, Elias. And for acute vertebral fractures, this is a whole lecture in and of itself, but acute fractures, you avoid it because you inject the cement through a 13 or 11 gauge big pipe of needles that go in here. You inject the cement, and if it's an acute fracture, they tend to extravasate everywhere. We tend to not do that because although it is thick cement, it takes several minutes to harden. And if it hardens out here, it's not good. Or if it hardens in the spinal canal, of course, it's not good. So we try to wait at least several months for these patients to heal somewhat. And one of the indications for vertebroplasty or kyphoplasty is unrelenting pain that really is not controlled by conventional conservative measures. So we're not treating this fracture in terms of trying to increase the height, what kyphoplasty used to do. But I think that's going out of favor now because studies have recently shown that vertebroplasty is just simply injecting cement. Although it doesn't increase the height of the vertebral bodies, it does decrease the pain. So the clinical success of vertebroplasty is equivalent to kyphoplasty. Kyphoplasty is putting a big balloon, expanding the vertebral body up. It looks good on x-ray, but it has no clinical difference with vertebroplasty. So chronic, at least 6 months, I would say, compression fractures with no breakage of the posterior wall. These are indications for vertebroplasty, and they are very, very effective. Any other questions? Any radiology feature interventional radiologists in the room? Just out of curiosity. No one? Okay. Good. So I think this lecture would be very good for you guys because I'm not going into too terrible of details, but it is very good for all of you guys who are all becoming interns, taking care of patients next year. Okay. So that's the general overview of interventional, kind of very slow and not specific. But now what I want to do is describe disease processes that are both common and uncommon. Okay, it's kind of play with words here, but common and uncommon diseases, but commonly referred to interventional radiology for treatment. So we get both very common diseases and uncommon diseases, but they are many times, the interventional radiologists are the main ones that treat these disease processes. Again, as I said before, all interns and residents in almost all fields will come across these diseases that I'll be talking about. And you need to know what we can offer as interventional radiologists to help your patients. And also the goal would be to increase the visibility of IR and all the procedures that we do to help all you guys. And trust me, when you're taking care of patients in the hospital, you're on call, someone's bleeding, and you want to know what is available to you in terms of not only endoscopy, surgery, but also interventional radiology, which is very, very important of all hospital settings. Common diseases treated in interventional radiology: anatomy, pathophysiology, and then medical versus surgical versus interventional treatments. And this is according to the guidelines that was provided by your director, Dr. Tan. And we try to follow this, this guideline, which is very important. Okay, deep venous thrombosis. And many of you may have heard this, many of you not, but you will, all of you will know about this, at least in the beginning of next year as interns. Very common. Deep venous thrombosis occurs. Why? It's basically clots in the deep, big veins in the legs, not superficial veins, but deep vein thrombosis. Okay, and the reason why these clots occur is in medical school, in early medical school, you've learned that the Virchow's triad is composed of trauma to the veins or the legs or the arms, wherever the clots form, stasis, or it's an intrinsically hypercoagulable state of the blood from cancer usually. So Virchow's triad predisposes a patient to deep venous thrombosis, which many times not only causes pain in the legs and swelling, but here's the main reason why everybody's scared. These deep veins throw huge clots into the lungs, causes pulmonary embolism, and many of these patients don't survive. It's instant death. And so the patients with pulmonary emboli who receive medical ventilation, mechanical ventilation, and basically intubation and mechanical ventilation, or they go into cardiopulmonary resuscitation, or invasive treatments are needed, have a very high mortality rates of up to 80% if they're intubated, meaning this is just basically saying huge pulmonary emboli will cause death, high mortality rates. However, smaller pulmonary emboli who are stable enough to get procedures such as CT exams have much smaller rates of mortality. And here is a CT examination. It's a cross-sectional view of the pulmonary arteries. And again, this is a cross-section. Patient's head is going into the screen. The feet is coming out toward your face. And here is the ascending aorta, descending aorta. And here is the main pulmonary artery, the right pulmonary artery. This is a normal. Left pulmonary artery is nicely opacified with contrast X-ray dye. To your right is the same, it's a different patient, but it's the same anatomy. But the problem here is this big filling defect is a saddle embolus sitting, literally sitting on the main left and right pulmonary artery juncture, causing no flow to the pulmonary artery. So it's basically putting a plug into the hemodynamics of the heart. And so they die instantly if it's huge like this. But many pulmonary emboli are much smaller than this. Okay, so why am I talking about this? So in terms of management, medical therapy, when patients have pulmonary emboli, when you order a CAT scan on a patient with clinical suspicion and the radiologists, diagnostic radiologists say there are emboli in the first and second order branches of the pulmonary artery, then the main goal or the mainstay therapy is anticoagulation with Coumadin, Lovenox, Bedax, etc. But they get anticoagulated. Now, in many patients who have a DVT or deep venous thrombosis in the legs, they cannot get anticoagulation medicine because of whether they have recent strokes or recent surgery, and anticoagulation is contraindicated. And then they would need an Ivc filter. Okay, an Ivc filter simply is a metal mesh, and I'll show you the pictures, that are placed in the inferior vena cava to basically prevent clots to go into the lung from the legs to the lung. Absolute indication, meaning that you need to have an Ivc placed, is failed medical therapy. Like I said, they cannot get anticoagulation, or contraindications to anticoagulation, such as recent surgeries or recent strokes, hemorrhagic strokes, and they cannot get blood anticoagulation medicines. Relative indications are patients who are sick, who have low ejection fractions, and if they have a known pulmonary embolus and an existing additional clot sitting in the legs, and they cannot survive another hit with another pulmonary emboli, then many times we'd place a filter to prevent emboli. But it is a little controversial whether that's needed. And we can talk about that if you have specific questions. But in pre-op patients with high risk, like orthopedic surgery, that's also relatively a controversial topic, but filters have been placed. But the key to all this is when you ask for filters as interns and residents next year, these are very important indications to think about, but you have to remember that these filters must come out if possible. Filters left in are no-no. And in fact, they need to come out for sure. Some patients are 90 years old and sick, and they may have to just keep the filters forever. But if you place a filter, you need to have the interventional radiologist take it out if possible once they are anticoagulated. Contraindications are inferior vena cava thrombosis. Now that makes intuitive sense because if the entire IVC is thrombosed, the clots will not reach the pulmonary emboli, pulmonary arteries to cause pulmonary emboli. And chronic IV thrombosis. Arm DVT many times is really not necessary. I get a lot of requests for IVC filters for arm DVTs, but it's just simply hemodynamics, and the size of the arm veins are so small that Emboli to the pulmonary arteries from the arm is subclinical, meaning they don't know it. The body thrombolyzes it just subclinically, meaning the patients are not symptomatic. And we do this, I know this for a fact, because we declot arms, AV grafts in the arms for dialysis, and we send a lot of clots into the lung with no consequence. Mega IVCs that are huge, greater than 35 or 30 millimeters, we have special bird's nest filters, but that's not common. And of course, people who can get medical therapy, you should not get IVC filter because medical therapy is a primary treatment. Thrombolytics is different than anticoagulation. It's actually an active with TPA, tissue plasma activator is a active. It actively thrombolyses clots. It's not to prevent clots, but it actively thrombolyses the clots, and these are reserved for the huge life-threatening emboli in the lungs, and in those cases we would place infusion catheters into the pulmonary artery, infuse TPA up to 20 milligrams, but these are not commonly done. Again, as I said before, filters should always be retrievable if possible. And one of the main reasons is because studies have shown now that inferior vena cava filters may actually be thrombogenic itself, cause thrombus in the IVC, cause problems with leg swelling and all this. So once they go in, you request an IVC filter, make sure that you follow up in a month or 2 or 3 months and request these to be removed. In our practice here at Kaiser, the interventional radiologists have a clinic and we see all our patients back and we remove these actively. We call you guys, we call the primary doctors and make sure that they are definitely amenable to anticoagulation therapy, and then we remove them within a month usually. And so the problem is if you forget them, if you get to take it out within 6 months, or maybe even up to a year, the key is 1 year. After a year, now it becomes scarred, the thrombus, not thrombus, I'm sorry, the inferior vena cava filter gets scarred in the IVC, the legs get entrapped, and it becomes extremely, if not impossible, to take out. You will probably see these when you take an x-ray of the KUB, an x-ray of the abdomen on your patients. You'll see, what are those spaceships there? And these are just inferior vena cava filters. And I will tell you that there are a lot of different kinds, but the most commonly placed and safest ones are the ones we place, which is option or the select filter. These are all older ones. This is probably the worst filter ever made. It causes IVC thrombosis and it breaks and it goes to the heart. This is a no-no. If you see this on your x-ray, that's a very bad prognosis. And so they stopped putting these different types of designs, but the main ones you'll see is the option, which I place, and the select. These are very, very good filters that are durable, don't break, don't migrate, and can be removed. When you ask the interventional radiologist to remove these filters, it's an outpatient procedure. And I'm telling you this not because you'll be doing it, but this is what your patients will go through. We place a big sheath, it's a 9 or 10 French sheath through the interjugular vein, go through the heart and down into the IVC. And then as you can see, there's a snare, there's a little loop snare, and we grab onto the little hook. These filters, every one of these filters have a hook. We grab it, we place the sheath over it, collapse the legs, and the entire sheath is encased over the filter, and then we pull it out. Sometimes these legs get caught on a wall, and it becomes really, really difficult, even sometimes for filters that have been only for 3-4 months. And then we become a little bit more aggressive, place balloons, but these are very, very specialized procedures. Sometimes if we can't displace these filter legs with a balloon angioplasty, then we would have to laser these out, which is not fun. Next topic, uterine fibroid embolization. Fibroids are the most common benign tumor in women. It's one of the most common benign tumor in women. And the incidence is up to 40% in women in reproductive years. And the main symptoms that you'll see if you're a gynecologist or family medicine or even internists, they'll present with severe uterine bleeding, pelvic chronic pain, dyspareunia, having lots of pain during sex, and then urinary incontinence. These are real common complaints that these young women have. They cannot live like that. And so traditionally in the past, if they're severely symptomatic, they would undergo hysterectomy. That'll definitely cure it. But now these young women, they don't have a uterus, and so they can't have kids anymore. That's a problem. Sometimes they plop out 2 or 3 biggest fibroid tumors surgically, called a myomectomy, but that's not effective many times because bleeding fibroids may not be the biggest one that they take out. It could be multiple small ones that could be bleeding. Or they sometimes ablate it. Again, it's not as effective. Hormonally, medically, and minimally invasive or non-invasive treatment like hormone therapy with oral contraceptives or patches. But people don't like to take hormones. That's really not ideal for a lot of women. And then we have the interventional radiology procedure option, which is the UFE, which I'll be talking about. The key benefits of uterine fibroid embolization over surgery or hysterectomy or myomectomy is that all fibroids, bilateral uterine arteries feed the entire uterus, and I'll show you pictures of this, are treated. Not just one, not the biggest, but all of them. It really, it can affect future pregnancy, but I have patients who have been treated with a UFE procedure who've gotten pregnant without an issue. So future pregnancy possibility is preserved. And then it's minimal recovery is needed, only 1 day. I would say about 90% of women require more than, they get discharged on the first day. Very rarely do they have to stay a second or third day. But it takes about a week for them to feel better. And I'll talk about the reason for that, grogginess and discomfort a week after the procedure. And then rapid relief of uterine bleeding symptoms. Literally, these women who present mainly with bleeding, chronic bleeding, or heavy bleeding, the symptoms resolve very, very quickly within probably weeks. But the pressure from the mass effect will take probably up to 6 to 12 months because it's simply size. It takes a lot longer for the size to decrease. Technical success is simply defined as was the interventional radiologist able to access the uterine arteries and do the procedure, and it's 97%. It's very effective technically. But does it matter if the clinical success is low? Clinical success is, did this procedure relieve the symptoms of bleeding or pelvic pressure? And they say it's 85 to 87% in the literature, and in my experience is about 85, 87% as well. Very accurate. This is highly effective procedure for symptomatic uterine fibroids. Potential complications include, not common at all, but it's premature menopause in women who are less than 50 years old. Women who are 50, around 50, they go to menopause anyways. So people who are getting embolization at 50 or above, it's not an issue. But if I'm treating a patient who's 35, I talk about this potential complication because the medicine that we give to stop the blood flow to the uterine arteries can also reflux rarely into the ovarian arteries, which can cause problems. But again, it's very, very rare. I haven't seen it in my practice. Infection, abscesses occur if the fibroid that are being embolized are greater than 15 to 20 centimeters. I have a question here. Is there a size limit of fibroids and UFE stops being effective? Yes. So this is part of the reason, Elias, is if it gets greater than 15 to 20 centimeters, in my experience, the tumor mass, the bulk is so big that I think that it may be better to take the fibroid mass out or do a hysterectomy, because can you just think of it? If you stop the blood flow to this huge 25 centimeter mass in the pelvis, it's going to sit there and die, and the dead tissue is just so much that I think they'll be prone to abscesses. So that's not good. So my recommendation is not 15. I've changed it over the last decade or so, but about 20 centimeters or greater, I would say may not be the best option. Does that answer your question? Okay. And then this is very important for all of you guys, not just for interventional radiologists. Post-embolization syndrome, okay? Remember that. And it may be on the boards too. Post-embolization syndrome is regardless of what procedure, but if a vessel is embolized, the distal target organ will die. And that will cause fevers, leukocytosis or elevated white count, and abdominal pain and nausea. And so this is important to recognize first week of the procedure, because this mimics sepsis, infection, which is very unlikely in the first week of a procedure. Infections occur usually 2 to 3 weeks out. But if a patient gets embolized, if one of your patients gets embolized, whether the spleen or uterine artery embolization or whatever, or you have liver tumors that were embolized by interventional radiologists, and they get these symptoms, think of post-embolization syndrome, requires just supportive therapy with IV hydration, no antibiotics, no need to culture, is simply just lots of hydration, supportive pain medication, and supportive care the first several days of the procedure. So Aaron says, how many patients experience post-embolization syndrome? Good question. I would say in uterine artery embolizations for fibroid, almost all of them do. Yes, that's why they are hospitalized for a day. If post-embolization syndrome did not occur, this would be an outpatient procedure, because it's such a quick procedure. But we keep them overnight for IV hydration, pain control, and what we call patient-controlled anesthesia, where they press a button and they get narcotics for pain. And after the first day, they get much better and they get to go home, usually after the first day. Good question. So post-embolization syndrome is important. Indications, symptomatic. They have to be symptomatic with uterine fibroids. If they're not symptomatic, I don't care what the fibroids look like. You don't have to do anything, because these are not cancers. These are just benign tumors that cause symptoms. And so uterine fibroid symptom and health, really quality of life. This is a questionnaire that many people use. I just have a very simple system, and it's very effective for me. I ask them on a scale 1 to 10, how bad are your symptoms in terms of affecting your daily life? And they'll give me a number. And if it's 7, 8, 9, 10, I say yes, let's do it. You can't live like that. Or if they say it's 2, 3, I say don't do it, because I've noticed that the patients with least symptoms have the least amount of success clinically, because they were never symptomatic to start with. That makes sense? Okay. And then women with fibroids who do not want hysterectomy, this is a very important option for them. Contraindications to fibroembolization is, of course, pregnancy. You never ever want to do this, or you're going to abort it. Or endometrial cancer. Now, endometrial cancer in women, symptoms are usually bleeding right? It mimics fibroids. And so what we do is we mandatorily do endometrial biopsies before doing embolizations. If you do embolization in an endometrial cancer patient, it's not going to hurt it, but it's just going to delay the diagnosis. So you don't want to do that. You want to make sure the endometrial biopsy is done. So if you send a patient for urinary embolization, you gynecologists out there, endometrial biopsies are mandatory. Leiomyosarcoma, same thing. It's a sarcoma that's cancer, but they also cause bleeding and pain. This is extremely rare, but they do look a little bit more aggressive and have a little bit more of a characteristic view on MRI. Very hard to diagnose. Rarely you can have large AV vascular shunting in the artery, but this is extremely rare. I haven't seen it in 18 years. Some pictures. Here's types of fibroids. Okay, this is the uterus, this is the vagina, cervix. This is the left ovary, the right ovary, the fallopian tubes. Types of fibroids occur here, submucosal. This is what the pedunculated, subserosal. You histology buffs out there, remember the subserosal. Serosa is out here, is flopping in the wind here. And then mucosal is just underneath the mucosa. And then these tend to flop off after embolization. They come out in the uterus. And the women call me sometimes at nights, they're frantic. They're saying, I passed my uterus in the toilet. But I say, no, those are subserosal fibroids dying. So that's a good sign. And then there's submucosal, there's mural, intramural, this is the most common. So simply, we go into the right common femoral artery, place, again, the sheath using a Seldinger technique, place a catheter, a microcatheter down, and this is a larger picture of that. This is my catheter. These are little beads, what we call polyvinyl alcohol. There's so many different types of embolic material you can use, but basically it's polyvinyl alcohol. It's an inert substance that comes in different sizes, and then you can block off these arteries. You just embolize the entire uterine artery, and that's the reason why you could actually treat all of the fibroids. Everybody hear me still? I think I lost my microphone. Okay. Okay, so here's a real live picture of a uterine artery embolization. Here's what a uterine artery looks like before embolization. It looks like a little worm. And here's a huge fibroid that typically has, I apologize for this blurriness, but these are little vessels that feed the tumor fibroid. There are smaller fibroids probably here, but when you embolize the entire uterine artery, the entire fibroids, not only one, but multiple fibroids die. Here is a post-embolization picture. You squirt the X-ray dye, and you no longer see the fibroids. Okay, now, many of you will ask, what happens to the uterus when you embolize both uterine arteries, right? Will the uterus die? How could someone have a baby with a dead uterus? And that's a very common question, but the radiologists in the past, very exquisite studies where they teamed up with a pathologist. I can't quote the exact study, but it was a nice study many, many years ago, where they embolized both arteries, and they actually took out the uterus, and they looked under a microscope, and they found out that when you embolize uterine arteries, these fibroids act like sumps, like suctions, like vacuums, and they suck up the majority of these emboli. And so what they saw under the microscope was dead fibroids, ischemic fibroids, but living uterine wall. So very interesting. So that's the reason why we could embolize the uterine arteries ad nauseum without worrying about infarcting the uterus. These are little vacuums sucking up all the embolic material. Very interesting dynamics. That's why we can embolize bilateral uterine arteries, and the women can still get pregnant and have an intact uterus. Okay, should we take a 5-10 minute break? No. Keep going, finish a little early. Are you all sleeping, or is this somewhat interesting? Be honest. Okay. How about if we take a 2 to 3 minute break for those who needs to go to the restroom, and we'll start back in about I don't know, at 3:25. Sounds good? 3 minute break. We'll start closer to 3:25 or so. 3:25. All right. Let's take a break. Thank you. Okay, so continuing on, we will now talk about cholecystitis. And I know that many of you know what cholecystitis is, or gallbladder inflammation. And many times in the past, the traditional therapy would be surgical resection or cholecystectomy. And the indications for surgery is most cholecystitis. However, there are a subgroup of patients that are either poor surgical candidates that cannot undergo surgery or general anesthesia because of either heart disease or lung disease or what have you. They're intubated or they're very sick. And there are many times acalculous cholecystitis, which the gallbladder is inflamed without the presence of gallstones. They're just inflamed, and there are many causes of that. And then there's severe sepsis and unstable patients who will die probably from getting surgery when the liver is exposed and the bile, the peritoneum is exposed, and there's a high risk for generalized sepsis and death from surgery. And these subgroup of patients who are sick, usually in-house, in the hospital, are candidates for percutaneous cholecystostomy drainage by interventional radiologists. And so here's some CT images of an acute cholecystitis where the gallbladder is inflamed in a very sick patient. Again, this is a cross-sectional images. This is the liver, the spleen, the stomach, the kidneys, and this is the celiac artery, aorta. Gallbladder is huge, inflamed, and this patient was not deemed a surgical candidate, and so they asked us to place a percutaneous, meaning percutaneous just means through the skin, cholecystostomy drainage. And the way that we do this is we always make sure that we go through the liver, some liver parenchyma, and not just hit the gallbladder. And the reason is because if you just hit the gallbladder, many times the gallbladder could rupture, and the bile, infected bile, will spill all around the abdominal cavity, cause severe bile peritonitis and death. Very, very common, a very scary situation. So the teaching is we go through the liver, place a wire, again, dilate up and place a little tube, and this is an example of what it looks like with a drainage catheter in the gallbladder through the liver, and you squirt X-ray dye full of gallstones, and now the patient is decompressed and stable enough to undergo surgery later on. And so one of the most important things to get out of this cholecystitis for you guys as interns and residents next year, cholecystitis, you'll see this no matter what, is very common. And if your patients undergo interventional radiology cholecystostomy, it's important that you keep these tubes in for a minimum of 6 weeks. This is a key, 6 weeks. And the reason why that number is important is if you pull this catheter out before 6 weeks is minimum, then the bile many times will, if there's no tract formed for 6 weeks, the bile will leak out and cause bile peritonitis. Bile peritonitis is very ugly. It's very painful, very serious problem because the bile is very irritating to the peritoneum. And so you don't want bile peritonitis. And so when they take this tube out, you want to make sure that there's a tube tract that forms within probably 4 to 6 weeks. So when you take this tube out, the excess bile will come out this way and not into the peritoneum. That's the reason why you need to have the tubes in for 6 weeks. This is a very important thing that you should always remember. That's a question that you'll have on a test later on. Next topic is oncology. Okay, this is a very, very important topic to discuss with interventional, because I think I work with oncologists more than any other subspecialists, oncologists and nephrologists. So oncology is a field of cancer treatment by cancer physicians, and we offer special procedures such as embolotherapy, which is things like TACE, which is, it's actually an embolization of tumors that are not resectable by surgery. It's chemoembolization, transarterial chemoembolization. And I'm sure many of you have heard of Y90, which is iridium, which is a radioactive bead injection into the tumors that treat the tumors long after you pull out the catheter. So it's relatively a new way of treating liver cancers. And then there's bland embolization, which is particles just like the particles we use with uterine artery embolization. You just stop the blood flow. But I think the most common procedures that are done now for liver tumors for oncologists are TACE, transarterial chemoembolization. You inject chemotherapy and embollium material to stop the blood flow to the tumors. And the goal many times is to shrink the size of the tumor so they can be surgically resected, or non-surgical patients. And then these are usually indicated for hepatomas and metastatic diseases. I'll show you some examples of those. And then there's ablative therapies, which I do regularly. This is becoming a lot more commonly performed now, especially cryoablation, which is freezing with temperature in the -30 range, where there's tissue death. Or there's thermal, things like with microwave and radio frequency, that's heat. But I think cryoablation has a role, and heat, radio frequency, microwave has a role depending on the organ location. So for example, renal cell cancer is best treated by cryo, lung cancer, liver cancer are best treated, I think, by microwave. I think radio frequency is falling out of practice because microwave is so effectively, it's so much more effective and so much quicker and precise. These are all cutting edge things that are going on now. And also, one of the procedures that I've added on to my practice with oncologists is immunotherapy. Immunotherapy is something that's very interesting now. For example, one of the agents that I inject directly into tumors, especially for metastatic melanoma, is TVEC. And TVEC is a immunotherapy. Immunotherapy is a cancer treatment that directly kills cancer cells, and it uses the body's immune system to fight these cancers like metastatic melanoma. So basically, engineer viruses that infect cancer cells through the immune system and kill the cancer cells and improve their long-term prognosis. I personally have worked with oncologists when I injected these TVEC into these melanoma mets. I've seen some of these melanoma lesions almost disappear. And so whether they have long-term prognosis effects, it's still up in the air, but I think it definitely is effective. Again, whether this will significantly improve the longevity of cancer patients, how much, I think is still up to some research, but I've seen this occur myself, not just in literature. And again, let's see, is this widely used or only at certain centers such as academic centers? A very good question, John. TVAC is very interesting. Immunotherapy oncologists are getting really excited about this. And just a year ago, Kaiser Riverside were very high, a high volume place for oncology for all of Kaiser. So we get a lot of referrals. And so we actually at Kaiser Riverside was the first to inject TVAC in all of Southern California a year ago. And so I know that this is becoming a little bit more widespread, but I know that this is extremely, extremely expensive. And I'm sure the costs will go down soon, but I know that some institutions do this. You're right, it is a lot of academic places, but I know that St. Jude's in Fullerton may be doing this as well, but it has a lot of promise. And as interventional radiologists, we're not only injecting these into the tumors, but I'm sure in the future we can actually put catheters into tumors and inject these that way. But this is very minimally invasive, very effective, and the type of viruses that we use is a herpes virus. And so the complication is, of course, viremia and fevers and things like that. But it's a very, very minimally invasive, interesting procedure. I wanted to include that, but I don't think that anybody's really going to test you on that. Sounds very promising. Yes, absolutely. I agree with you. Okay, so continuing on. So has TVAC only been used in melanoma? Yes. I believe that TVAC is right now used for metastatic melanoma, not primary melanoma, but metastatic melanoma to the liver, to the skin, to the joints, to the soft tissues. So there may be other indications, but I know that metastatic melanoma is the ones that we treat with TVAC here at Kaiser so far. Interventional radiologists treat by ablating using thermal freezing, and also targeted chemotherapy, like I talked about, embolization with chemotherapy agents or iridium, or again, direct injections. And again, the goal is symptomatic relief, palliative for stage 4 and on patients who need pain control, whether it's long-term tunnel catheters we place, or we place metallic biliary stents that they don't have tubes hanging out when they pass away. It's all about quality of life. And a lot of these procedures that we do for oncology patients are not only to fight cancer, but also for palliative measures as well. And here's an example of a lesion in the right. Again, this is a cross-section of the liver. Again, the head's going towards the inside the screen, feet's coming out towards you. Liver, heart, part of the stomach, the lungs, aorta, part of the celiac artery. And here's the liver, portal vein. And here's a little enhancing lesion that is solitary. And so the surgeons ask, hey, can you ablate this solitary lesion? And the answer is yes. And so this is not my slide, but this is an older slide where they use radio frequency, where there's a little hook. We don't do this anymore. We actually place, we don't use radio frequency, but we actually use microwave, which is a much more robust, effective therapy for tumors in the liver. It literally just incinerates the tumor with a much sharper margin, controlled margin than radio frequency. So think microwave. And so we ablate this and the patient's cured. They don't need surgery to remove this focus of metastatic disease or primary. And time is about 60 minutes. This is my slide. Actually, this is my patient with no name. This is for confidentiality. This is my patient on the CT interventional table. And this is a patient who, again, this is prone, stomach's down here, patient's on a stomach. And here's a left kidney with a tumor right here. It's about 2 centimeter tumor. Here's my needle, cryoablation needle. I use 2. And these externally, these white needles are the cryoprobes that circulate certain neon gases, as well as, I mean, the temperature goes down to -30, which is the goal for tissue necrosis. And once we hit 30 degrees, -30 degrees, the tumor, we control the size of the freeze. We try to get a little bit beyond the margin of the tumor to get nice clear margins. And we biopsy the lesion before we treat to get the sample. And then sometimes when there's a lot of bowel, such as like in this case colon, we have to place another needle to move the bowel away with fluid dissection. We inject normal saline. We move bowel away to make sure that there's no injury to the bowel as we freeze this tumor. And at Kaiser, we're very busy doing these cases, and it's we do these every week, several patients, and our results have been extremely promising, equivalent to surgery for tumors less than 3 centimeters. If it's greater than 3 centimeters, I think it's less success. But cryoablation for cancer is extremely, extremely effective. Okay, one of the last topics that we're going to talk about is portal hypertension. Now, portal hypertension is not necessarily a disease entity, but it's a symptom, a sequela of many diseases of the liver. And all it is saying that there's increased pressure in the portal system. And it's a problem because when a patient has portal hypertension, the secondary complication of that is severe bleeding. Okay, and when you're an intern or a resident next year, for the next several years, you will see patients, I guarantee you will see patients with portal hypertension because of liver disease. Very, very common. And I want to expose all of you guys to this so you won't be hit all at once next year. So normal anatomy is, here's the liver. Remember the gross anatomy classes, the left and right portal. You cannot access the portal system directly because it's an internal system. So it's basically a venous system where it drains all the small and large bowel. The blood comes this way. After you eat, all the nutrients go in this way into the portal, main portal vein, into the liver. It gets filtered and goes into the heart. The spleen also has a splenic vein that joins inferior mesenteric vein, drains the small bowel as well. Left gastric vein, all these veins converge into the main portal vein. And there are little collaterals that are almost non-existent. You can't see these normally if there's no portal hypertension. Here's another schematic of the portal veins. Again, aorta is here. The vein, the inferior vena cava is separate here. And the portal vein is, again, is an internal system that drains the bowel into the liver. Okay, this is anatomy. You have to know the anatomy. So there are many causes of portal hypertension. I'm not going to bore you with all of these, but pre-hepatic, before the portal venous system, there's things like portal vein thrombosis or portal vein atresia. Post-hepatic meaning after. Post-hepatic means like beyond the liver parenchyma, not in the liver. But more commonly, I think, the portal hypertension is caused by intrahepatic causes, such as alcohol, hepatitis B and C infections, cirrhosis caused by fatty liver, NASH, non-alcoholic steatohepatitis, Very, very common now in young people too. So fatty liver, hepatitis B and C, alcohol, all causes cirrhosis, are predisposed to cirrhosis. There are less common things like Wilson's disease, hemochromatosis, cystic fibrosis, primary screening, all these, even parasite infections, all these occur, but I guarantee this is the most common. You'll see alcohol, hepatitis, fatty liver causing cirrhosis, and this is what causes portal hypertension. You saw the normal anatomy on the previous slides. This is what a sort of a nice picture of a cirrhotic liver looks like. It looks like all these regenerating nodules is basically chronic injury to the liver, and the liver gets scarred. It becomes like a rock. And so the pathophysiology of cirrhosis and portal hypertension is because the liver becomes like a rock, all the veins coming in gets blocked. And the vein has to collateralize, meaning all the blood volume needs to go somewhere, reach the heart. So these little tiny veins get huge. It's called coronary veins, or varices, and you've heard of esophageal varices or gastric varices or splenic vein varices. All these varices occur as the body tries to compensate to bypass the liver. The problem is that these veins are not used to having that kind of a volume of blood, and so they burst. They burst into the esophagus, they burst into the stomach, and these patients come with massive upper GI bleeding. Upper GI bleeding, okay? Sometimes lower GI bleeding due to hemorrhoids because of the same backup phenomenon. Here's a real picture of a portal venogram of a patient who came in with severe bleeding. Upper GI bleeding. The endoscopist, the GI physicians look at this with a scope and they say, oh my goodness, there's a lot of esophageal and gastric varices. I can't stop the bleeding. Please have the patient evaluate for interventional radiology for a procedure called TIPS. And so here we go through the liver, do a venogram, and then you see this big coronary varix, big varices, gastric varices, esophageal varices, and see this stream of contrast. This is bleeding. It's ruptured into the esophagus. The patient's throwing up blood. So what can interventional radiologists do to help this? And this is a procedure called TIPS, or transjugular intrahepatic portal systemic shunt. It's a long name, but just think of TIPS. And if a patient goes to endoscopy for upper GI bleeding and they can't stop the bleeding, or it's too much blood that they can't see with a scope, then the patient has to undergo TIPS. And I'm going to talk about the different contraindications and indications for this. And here's a very basic image diagram of what a TIPS is. Here's a portal. Here's the hepatic vein, portal vein, the liver, and the blood flow is going this way. And again, our goal is to somehow relieve the pressure of the portal hypertension by creating this artificial tract with a long needle. And then we place a wire down into the main portal vein. We place serial balloons, dilate it up to 12 millimeters usually. And then we place a covered stent across it, and now you have this blood not bypassing it anymore, but now you have blood going through the liver. Now you've created a shunt. Now the shunt will prevent all this pressure to be relieved, and all these gastric and coronary and esophageal varices will decompress, and the patient stops bleeding. Very effective. Here's a TIPS shunt, hepatic veins. Again, this is a real live picture of a TIPS shunt. We went through the internal jugular vein to the right atrium into the hepatic vein, pierced the liver, made a huge tract here, and placed a covered stent. And now all this blood is normally would have gone and bled. Now it's going through the TIPS stent into the heart. The varices are present. With the TIPS, it's gone. No TIPS, TIPS. No TIPS, TIPS, and then all the varices are gone. So the goal for a TIPS procedure is to relieve the portal pressure, and our goal is to have it less portal systemic gradient of less than 12. And why is that important? Portal systemic gradient is simply the pressure. You measure it in the heart, you measure it in the portal vein, and the gradient. What is the difference? And if we have it less than 12, they stop bleeding. Why is it 12? That's just what the studies show. 12 is a magic number, okay? So if it's 10, they stop bleeding. If it's 14, 15, there's still risk of bleeding. That's actually a very accurate number. And then after TIPS, for you guys, it's important to follow the patients every 6 months with ultrasound to make sure that the TIPS is patent and open. If not, we got to balloon that again. And also for you guys as interns and residents next year, and also for board exams, Meld Score is important to know. And this is a model for end-stage liver disease. It's simply a score to delineate how sick the liver is for the patient when it's cirrhotic. And it ranges from 6 to 40. You don't have to go into the specifics, but just know that the Meld Score ranks a patient's degree of liver sickness. And it helps to prioritize hepatologists and interventional radiologists for liver transplant and whether they will do okay with TIPS or not. It's important to get a Meld Score because if the liver is too sick and you do a TIPS, you will kill the patient over a period of weeks to months. Okay, it's very important because the liver depends on the portal vein to live because it's supplied by the portal vein. The liver, like any other organ, needs blood supply, and it's supplied by the portal vein. And if you bypass the liver, as sick as it is, will not be happy if all the blood is bypassed through a TIPS. And so it's important to measure the Meld Score. And the Meld Score is calculated simply by patient's creatinine, INR levels, how coagulopathic the patient is, and total serum bilirubin. These are just simple numbers. And Meld scores of probably less than 20 is very, very important. Your Meld score of greater than 15 to 20, it's very, very high risk for hepatic failure. And patients who have recurrent ascites from portal hypertension, we can talk about that too, but that's one of the complications of portal hypertension, ascites. You want to make sure the Meld score is at least less than 10 to make sure that he doesn't have complications of liver failure. Any questions before I keep going about TIPS? You guys still awake? Okay. So it's important that you know that the indications for a TIPS is acute life-threatening visceral bleed that has failed endoscopic intervention, and relative indication is things like ascites and hydrothorax pleural effusion. And do you understand why ascites and pleural effusion is a complication? Same reason as bleeding. Everything backs up, and as the liver is cirrhotic, all the blood cannot get through to the liver, so it backs up not only the blood, but also the serum seeps out, and the patient gets ascites and pleural effusions, third spacing. And so TIPS will help relieve that. But it's all about risk benefit, because if a patient has a very high Meld score and you do a TIPS for ascites who they could live with, they can drain this periodically. But if the patient has a high Meld score and you do a TIPS for ascites, it doesn't make sense because the TIPS has a higher risk because of the Meld score. Does that make sense? Okay. Absolute contraindication for TIPS is portal vein thrombosis. That makes intuitive sense, right? If the portal vein is thrombosed, it's gone. If this portal vein is thrombosed, there's no target for the tips. So that's a contraindication. And the way to tell is to get a simple ultrasound. If you're if you're asking for tips for interventional radiology, always order an ultrasound for the portal vein to make sure that it's open. Splenic vein thrombosis is also a contraindication because placing a TIPS will not help. And this is a little bit more complex to understand, but splenic vein thrombosis, TIPS will not help. Okay, it's another procedure can help, but for the purposes of this lecture, Meld scores greater than 15 are a contraindication. Greater than 10 is a contraindication for ascites. Okay, these are important. And then relative contraindication are tumors and masses in the liver. The problem with having tumors in the masses in the way is if you place a stent through a tumor, it'll bleed out and kill the patient. It's very risky that way, but it's all about risk benefit again. If the tumors are small and the patient's bleeding out massively, then you have to do a TIPS no matter what. Severe right heart failure is a relative contraindication because all that blood going through the tip stent into the right heart that's already failing will also put the heart into worse failure. And then again, polycystic liver disease going through the big cyst will bleed into the cyst and have a risk of bleeding out. But again, here's the caveat. There are no real absolute contraindications for massive uncontrolled GI bleeders. And I've had people come into the ER or the GI physicians call and they say, this patient is bleeding out. We got to do something. All this is irrelevant. If the patient is bleeding out, you do a TIPS to try to save the patient. Because if you don't, he's going to die immediately. Okay, and one of the last ones. Again, so we're almost there. Another 10 minutes or so. Hang in there. Vascular stenting, and there are so many different types of vascular stenting that we do, but I bring this up because this is a very interesting phenomenon that could show up on your boards. You may not see it in the next year or two as interns, but very interesting. Blocked subclavian artery, okay? Here is the aortogram, ascending aorta, arch, descending thoracic aorta, okay? Your anatomy, remember, this is the brachiocephalic artery, right common carotid artery, subclavian artery. The left common carotid artery, and then there's supposed to be a subclavian artery coming here. Here's the subclavian artery here, but this segment is gone because it's blocked due to atherosclerotic disease, and there's a blockage right here. And so the reason why this subclavian artery is filled is because the vertebral artery comes down and supplies this subclavian artery. And okay, I'm trying to find the, yes. So when you have a blocked subclavian artery, like I just showed you, it's called the subclavian steal syndrome. Important to know for your boards. The patient has ipsilateral arm pain, weakness, and dizziness when turning the head to the same side. So the patient turns his head to the left, they get arm pain, weakness, and dizziness. And you think of subclavian steal syndrome, and you get an ultrasound, and then you see reversal of blood flow into the vertebral artery, because normally the vertebral artery comes off the subclavian arteries and shoot up to supply the cerebellum, right? Posterior circulation. But with this narrowing, the subclavian artery steals the blood from this vertebral artery coming down. You won't see it here, but vertebral artery has reversal of flow. Normally it should be going up, but it goes down to supply the arm. So the patient gets dizzy because there's not enough blood going to the brain. And so this is a subclavian steal phenomenon, and the treatment, the only treatment, is endovascular therapy with angioplasty and stenting. Not really surgery, because surgery you can fix it or bypass it, but it has a lot more morbidity, Morbidity, lots of recovery time, a lot more surgical intervention, which is a lot more invasive. And what we do is we go in, place a metal stent across, cross it with a wire, place a wire, and we place a stent across the occlusion, and now the blood flow is once again in the correct direction, going into the vertebral artery and as well as into the subclavian artery, and the patient's symptoms resolve. Major surgery avoided, and the procedure time is about 1 to 2 hours. A very interesting phenomenon. Last topic is aortic aneurysms. Okay. Any questions about subclavian steel before I go on? Everybody still awake? Good. Just read about that. If you have any questions, we can also talk about that, but these are very important key topics that you should know. Last topic is abdominal aortic aneurysms. How often have you seen subclavian steel? Very good question. Subclavian steel is not uncommon, actually. I can't give you a number, but in a course of a year, I come across probably 2 or 3 cases, but a lot of them are non-operative because a lot of these patients are not symptomatic. You do an ultrasound of the neck for carotid, and you see a reversal of flow in the vertebral artery, but the patient's asymptomatic. It's all about the symptoms, and so if they're asymptomatic, you don't really have to work it up as much, but if the patient comes with symptoms of dizziness and arm pain, then you do it, and you have to work it up. So it's not necessarily incidental finding. If I do a Doppler ultrasound of the neck and I see reversal of flow in the vertebral artery, I would talk to the primary physicians, which is maybe you guys, internists and family medicine physicians, and say, hey, you should keep this in the back of your mind. If the patient has symptoms such as dizziness, arm pain on the same side, you should consider subclavian steel, and then the workup starts. Does that make sense? So if the patient's symptomatic, you work it up. But if I see it incidentally on an ultrasound, I would call you guys up and you report and see if they're symptomatic. Very important. So abnormal bulge of the aorta is defined as an aneurysm, and the risk of rupture is the main worry. And the size has direct correlation with the risk of rupture. So sizes that range, they say, from 6 to 6.9 has a 10 to 20% rupture rate per year. Leave an aneurysm that's 7 to 8 centimeters has a 20 to 40% rupture and instant death, or greater than 8 up to 50%. So these are like time bombs. And so abdominal aortic aneurysm, now I'm not talking about thoracic aortic aneurysms, that's a whole different story, but for the purposes of our discussion, I think this is a very common entity, a AAA, they call it, abdominal aortic aneurysm. So aneurysms that range from 5 to 5.5 is when a lot of surgeons will electively decide to repair aneurysms. In the past, even 20 years ago, the aorta was treated by surgical excision and graft placement, open AAA repair. But I think a lot more, I think the majority of our AAAs are now treated with endovascular therapy, excluding the aneurysm. Remember I showed you the angiogram. Again, I'm sorry for this old slide, but here's a better schematic. Good question. Is do you repair aneurysms that are symptomatic, or do all AAAs get repaired based on size? It is based on size. And if you're symptomatic from a AAA, meaning you have back pain, and hypotension, then it's too late. I mean, that's an emergency. But if a lot of patients with AAAs, they do have bounding pulses in their abdomen, you know, the classic, and then you get an ultrasound and there's a big aneurysm there. So the size is critical in determining treatment for AAAs. It's one of the rare things that completely depend on size and not necessarily symptoms. But you're right. Most of cases that we do, John, is we treat when they're symptomatic, but AAAs are different. AAAs are an exception because if they rupture, the consequences is disastrous. And so that's why the size is important, 5 to 5.5. Okay, so if you see an aneurysm, you do a Doppler, you see a patient in your clinic or ER in a 60, 70, 80-year-old male, usually smokers, and you get an ultrasound that shows a 6-centimeter aneurysm, you got to call the vascular surgeon and say, hey, you got to get him in your clinic to get this repaired. Okay. All right, so open repair has mortalities of up to 50% for ruptured AAAs, But endovascular repair has lower mortality, but it's still significant, but it's quicker and it actually has been proven to be very effective for ruptured and unruptured AAAs. And the way we do this, and then the vascular surgeons and the interventional radiologists usually do this together, and the vascular surgeons would do cut downs, place these large sheaths into the common femoral artery. Again, same concept, big sheath, place these stents, this body of the stent above the aneurysm into the neck, deploy it, and go to the contralateral other side and place another stent, which is the contralateral limb. And these are all sized before. You deploy it, and you tack this with balloons, and you do a completion angiogram, and now you have excluded the aneurysm, meaning the blood flow goes through the graft now and not into the aneurysm. And you have effectively treated the aneurysm. After deployment, we follow these aneurysms with serial CTA or CT angiogram exams, not ultrasound, looking for leaks. And I'm not sure if they'll test you on this, but the most important thing for you guys to know is type 2 endoleak, which is leaks that occur due to residual blood vessels like the lumbar artery or the mesenteric arteries that feed the aneurysm. Blood still flows into the sac, and the sac grows, and the sac is still at risk for rupturing. And so if that occurs, or type 2, which is the most common, the interventional radiologists or vascular surgeons would go in there and embolize these arteries. And then we continue to follow. So rarely they would direct puncture these aneurysms with a needle and inject coils or thrombogenic material and hopefully clot this aneurysm sac, but more commonly we would embolize the feeding arteries. Type 1, just for the sake of academics, is graft attachment leaks. Not important for you guys, but these are all these different types of leaks. But remember, type 2 is probably the most common. And when a vascular surgeon or an IR physician talk about leaks, it's the type 2 where there's vessels, residual vessels that feed the sac. So I've discussed lots of different common diseases and not as common disease, but commonly treated in IR. Hepatobiliary, TIPS, and cholecystitis treatments are probably very common and probably most effectively treated by interventional radiologists. Oncology, we talked about very briefly different types of interventional oncology. Very promising immunotherapy in the future. gynecologic. There's so many different types, but uterine artery fiber embolization is by far the most common procedure we do for gynecologists. And then vascular, we talked about AAA, very basic concepts, but important concepts to know for your patients that you'll be taking care of. And then we talked about subclavian steel. We didn't talk about these things, but it's not as common. And then we did talk about the DVT, pulmonary embolism, and then Ivc filter, and the importance of retrieval within when? As soon as possible. And I think the limit is about up to a year, and then it becomes permanent. So it becomes a problem ever taking these out. Any other final questions before I end? It's 4:10. I think we're done. Any questions about anything? Okay, and I hope that you remember these concepts, and as you finish your last year in fourth year medicine, or fourth year as a medical student, and I think that interventional radiology will hopefully help you guys take care of your patients in the next several years. Okay, thank you very much, and have a good rest of the day.